Dr. Wu, it's a very long question, but the bottom line is there any known genetic connection between Parkinson's disease and dystonias?
Yeah, so the question is there a connection between Parkinson's disease and the dystonias? So dystonia, so the answer is yes and no. So dystonia is both a disorder on its own, which most of you probably have, but perhaps not all, where dystonia applies in one or a fixed part of the body, and that's the only problem that exists. The flip side is that Parkinson's disease, which is its own disorder, which has its own brain basis, that is a neurodegenerative condition, presents with what's the symptom of dystonia.
Okay, another question. I lost the question. Was essentially, is PET scanning of any use in the investigation or research with blepharospasm?
Yeah, so I'm not aware of any. I take that back. I think there is one PET scan study, I don't know it off the top of my head, that's been done in blepharospasm that I've come across, but it's not in any standard clinical use. There is a PET scan that's used in diagnosing certain types of tremor in Parkinson's disease and certain conditions, but in the routine use for dystonia, it's not. It would be a research tool, and I'm not aware of a lot of active studies with that. It depends on what you're looking for. And from the stuff I discussed this morning, it doesn't directly relate.
This is for the panel in general. I had numerous questions on this. What about acupuncture in the treatment of blepharospasm? Any experience on the panel? Does it work? Does it not work? Has anybody tried it?
Yeah. Ask the audience. I bet you more than a few people have tried it.
I bet that's right. And does it work?
Who has it worked on? Oh, just like Valium, temporarily.
Okay. For the panel, is there any way to prolong the effects of the injections?
Well,
Is there anything you can give or have the patient do to prolong the injections?
Well, I was going to mention Zytase. Zytase is being marketed as something that makes it more effective, Botox more effective, and perhaps to last longer. I have limited experience with it, and it's been somewhat mixed. Some of my patients have felt like it helped them, and some have said they've seen no difference. I can't imagine. I can't understand how it would actually make it last longer. I can understand how it might potentiate the original effect, though.
Again, I'd love to query. You guys are all experts, so let's query the audience. How many people have used Zytase and found it helpful? How many people have used Zytase and have not found it helpful? Okay, so really, very few people have used it. You know, 3, 4 on each side. So we don't have an extensive experience. I have to admit, I'd never heard of it until today, until I went out, and now I have my sample, and I'll try it on one of my next patients.
This is actually for Dr. Afshari and for Dr. Edwards. Are there any recommendations at the timing of cataract surgery after the Botox injections, and is there any reason not to have cataract surgery if you have blepharospasm?
So no reason not to have cataract surgery. In fact, a lot of the folks that we see do have cataracts, and at some point they're having cataract surgery. Of course, we watch the ocular surface a little more closely. Why? Because anybody who has dry eyes may have a little more discomfort, and cataract surgery involves a wound that would disrupting just the nerve area in the cornea in that area. But cataract being the lens inside the eye, so it's in a way separate issues.
I don't think that you really have to worry about the timing of cataract surgery and your injections, but it may be a little easier and you may be a little more comfortable if you have the surgery several weeks after an effective set of injections and not when the Botox is worn off.
I have a couple of questions here that I'd like to sort of get into to address something that I've seen. One of the questions said that patients being treated by a neurologist, but the injections are not working very well, and the neurologist will not go above 50 units. And another question said that they were getting 150 units, and is that too much? Will it cause the botulinum toxin to not become effective? I see a lot of patients that fall into the no more than 50 unit group. Ben, you're shaking your head
Well, I mean,
with this look of haughty derision.
There's plenty of patients that require more than 50, and at a meeting at the North American Ophthalmology Society meeting a few years ago, we addressed this in a session, and a lot of people are using up to 100 without any issues. And we'll talk a little bit in my lecture this afternoon about what you do when toxin isn't effective. But I have 50 is often not enough.
I agree, 50 is often not enough. I think if patients are getting a fairly large amount and they're finding that the treatment is still just not working, then they may need to look at some of the other alternatives, I guess specifically orbicularis myectomy, which will frequently make it so that the use of botulinum toxin is more effective. I have not seen, I think, any patients who had myectomy and were cured, but I've seen a lot of patients who had myectomy and then the Botox seemed to work much better and they were much better controlled.
One of the things that I've been impressed with is this thing that Dr. Edwards said, that patients will come in and say the Botox isn't working. And he showed in his lecture that you have to make sure, like when he talked about remissions, and that may not have been Botox, may not have been blepharospasm to begin with. And there are a lot of things that are mistaken for blepharospasm, but really, really aren't. Have any of you seen a true remission?
No. I was thinking about it when I was doing the talk and then again when I was hearing talks. What I have seen that I haven't understood is I've had several patients with Meigs syndrome. They would present looking like blepharospasm and over a period of a year or so develop what appears to be a mild or moderate form of Meigs, and they get treated once or twice in the lower face, and then the Meigs has disappeared from the screen as a problem. But I've never seen somebody with benign essential blepharospasm resolve.
There's only one paper in the literature that says that there's a certain percentage, and I forget the percentage, that spontaneously resolve, and that was written by Neil Miller from Baltimore. And it was funny because I was at this meeting in Baltimore, and one of his patients stood up and said, "Oh yes, I'm one of the people where it resolved and I don't have the problem anymore." and he had obvious blepharospasm. And I asked Neil afterwards, I said, "How did you sort of decide that these people had spontaneous resolution?" He said, "Well, they didn't come back," and I called them and they said they didn't come back because they were better. So now what I do see also is that, which I think is one of the major issues in the botulinum toxin not working. I think, I don't know if Russ mentioned it, but some of it I think is apraxia, that if it doesn't work, it's probably apraxia. It may be apraxia, or it may not be blepharospasm. One of the things that I do when a patient comes in and they said that the injections didn't work is I test their strength of their eyelid opening. In other words, I say, squeeze your eyes, and if I can open their lids with just the minimum amount of pressure, The injections worked. Injections did what they were supposed to do. It's just that they didn't open their eyes. And I see people who come in, and this is what I wanted to get from you. When they go back to some people, they say, oh, well, we'll give you some more. What is the interval that you use between injections? Is there an interval within which you won't give another injection, and why?
I don't think I have a specific interval, but when a patient comes back and says it didn't work, I usually try to find out what they mean by it didn't work. For example, as you mentioned, you may see that clearly the muscles are weak and they're just not able to open their eyes. Some patients will say it didn't work and they can point to an area where they're still having some spasm and that seems to trigger it. If they have that, I will touch them up even within a few weeks of the original treatment. There are patients who seem to, it works for 4, 6, 8 weeks and then they need to return even though, it hasn't been 3 months. So I tailor it according to the patient, and I also always ask them if the last set worked, and if it's a patient that I've been treating for a long time and it's almost always worked and I do the same pattern and it didn't work, we usually just try the same thing, and most of the time we don't know why it didn't work, but the next one works well again. And if it doesn't, then I consider other things.
Ben, what do you do?
I don't do touch-ups. So at least there's a theoretical argument that by giving a protein too quickly, there's a possibility of antibody formation. In the early days of, especially with Botox, there was a large protein load of the complexing protein, and the incidence of developing antibodies and then antibody-related resistance, it would block the utility. That kind of went away when in the last 15 years, they make it with a different process. It's cleaner, has less complexing protein, so it's said that unless people are getting very high doses of Botox, which we use with some of the Dystonias, people get 300 and 400 units, there still can be some of that. So that's one of the reasons I don't do touch-ups. I'll treat somebody 8 or 9 weeks out if they're wearing off too quickly, but I usually don't do it 3 or 4 weeks later.
Allan?
Yeah, I'm also fairly conservative about it. I don't do touch-ups. I think it's a very individual thing between you and your doctor. So the standard of care is the 3-month interval, but that is pretty much an arbitrary number that came out of the literature back when there was these protein problems that Ben was referring to. So I do go down to as low as 10 weeks and then to 8 weeks if needed for certain people. It varies a lot depending on the dosing pattern they're getting. I also will do the Frontalis tests where I try to demonstrate whether there is weakness, biological resistance, distinct from functional weakness.
Have you seen any cases of true resistance?
I have seen cases of true resistance, and I have 2 cases now that have gone through several toxins, being, I don't know, human petri dishes for antibodies, where we've actually taken people to surgery. But I think it's because we're a referral center and we get some pretty severe ones.
But in those patients, the muscles are not weak. Correct?
The muscles are not weak, and we'll actually inject their forehead on one side and make them take a photo of themselves or come in and get a photo taken of themselves trying to raise their eyebrows and show that there is biological resistance before we move on. But it's a pretty individual thing.
I think you can get in this downward cycle of getting injected too frequently. And when I see that, what I will do is I will give patients a washout period. I'll say no Botox for 3 months, and I'll wait until their lids are strong again, and then I will inject them, and it usually works. And I think that Botox works on everyone who has blepharospasm, in that it weakens the muscles on everyone who has blepharospasm. It doesn't cure the symptoms for other reasons, and that's what we need to sort of determine. Natalie, there are a couple of questions about restasis here. How often, when you have someone on restasis, how often should they be followed?
So So a lot of patients are on Restasis for dry eyes. Just for folks who haven't used Restasis, it's a cyclosporin. So it's a weak anti-inflammatory eye drop, which the potent kind of it is what in the pill format is used for anti-rejection of, for example, kidney transplant. So the very diluted, the very topical, low concentration type is used as an anti-inflammatory for dry eye syndrome. So how often? They don't have to be very frequently followed up. So even some of them once every 6 months is okay. Folks can stay on it for months and months. Ideally, after a year or so, I try to get people off of Restasis, see how do they do without it, just because it is an anti-inflammatory medicine, to see if we can have a period without it. But usually it doesn't work for the first month or 3 weeks, and it only works in certain type of folks. So some people notice that they really like it, and some people say it doesn't help me at all and it burns some.
Another question about dry eyes. Is there some sort of contact lens that can be put on the eye during sleep to increase the tear production or something like that?
So I think one of our friends here asked about it during the break, and yes, so there are contact lenses that are like Band-Aid contact lenses. We call them bandage contact lenses. They have no prescription. They are, some of them are a little bigger or a little thicker or have high water content, and the purpose is to cover the cornea so there's less of moisture evaporation. We don't like the eyelid to be too open with bandage contact lens because it's still, that can dry up also and kind of get stuck to the cornea. So we like a lot of moisture with it, but it can be used during the day or stay in the eye as much as even 3 months. There are several different types. One of them, contour lens, Kontur. It's an unusual spelling, that can stay up to 3 months with a little bit of antibiotic eye drops every day. Since without it, there is a risk of infection anytime we keep contact lens in. They have to be loose. We don't want tight contact lenses, just like we don't want tight shoes. It kind of conforms and changes the curvature of the cornea. We want pretty loose fitting so oxygen can go in between blinking.
Someone said they had something called a meibomian oculation 4 years ago, and it was painful. Is this the same thing you were talking about?
So I think it was different in that, so we talked about meibomian glands, right, by the lid margins, that have the sort of the lipid-like material coming out, and having good secretions are good because we want to have healthy tear film, the good lipid layer. So some meibomian glands are blocked up, and we talked about warm water compressors or different techniques to get it out. There have been some folks who have actually needled the meibomian glands, sort of the orifices, to open them up. Now we say more of the either warm water compressors. There are actually lasers to do that, not quite as prevalent. But the LipiFlow system that we talked about, it's sort of the ultimate massaging of the eyelid with warmth. So it's like being in a spa, some warmth, and then some massaging of the eyelids to get the meibomian glands out, the secretions of it out.
Okay, there's a series of questions about other medications and blepharospasm. Can vitamins help or hurt blepharospasm in any way, panel?
Like chicken soup, it couldn't hurt.
Couldn't hurt, all right. Is there any class of antibiotics that should be avoided near the time of Botox injection?
No.
No. I mean, I don't know if anybody's sort of pushing that, but no.
I think they might be referring to gentamicin, because some of those do have a theoretical risk of affecting the neuromuscular junction. So there are, if you look at, if you get a drug or antibiotic that you're concerned about, you can just look that up and their side effect profile and see if it interacts with myasthenia gravis or neuromuscular junction disorders. And your doctor will be able to advise you on that. But it's mostly theoretical. I haven't come across it.
Natalie, how do you pick which artificial tear to use? Is it
So-
the one, the sample that you get from your doctor?
That's right, whatever is on sale. But ideally, what is preservative-free, right? So we don't want to introduce more preservatives that sometimes could cause inflammation of the eyelid, or we could have allergies to it, or more sort of need for rubbing or more discomfort. So preservative-free, usually they come in the little tubelets, as you notice. So they're more expensive because you can't keep them also as long, but those, and there is not one that we can say is certainly superior to the others. That's at least good for the sale or coupon system they have.
There was one I didn't see on your slide that I always show to patients because it's got a different application system and it's also preservative-free, and that's called Nature's Tears. And it's a little bottle of water that's preservative-free. It's got some electrolytes, so its balance is all right. And it's got compressed air, so it's in a little aerosol. It's like a miniature can of spray paint, and you point it at your face, and you push the button with your eyes open. Good luck with that. And it puts a little bit of water in your tear film. It's not enough that you have to wipe your eye dry, so you're not removing any of the oil, the lipid layer. The little droplets will just soak through the lipid layer and thicken the water film. It's hard to find. I think a lot of patients don't care for it because it's weird. But I also think that for some patients it's easier to use because you don't have to tip your head back and position yourself and wonder if you got it in and drip it all down your face. It's a mist, you just point it at your eye.
Actually, you probably can't get it in because your blink reflex would
That's
prevent it from getting in your eye.
And I
right?
think the best way to really keep artificial tears, and as Dr. Russell was actually alluding that it is difficult to put them in, is to hold the lower lid down, make that pocket, I think most folks are familiar, and drop a drop in there, ideally if the head is
That's
tilted.
exactly right. That's the way. I'm terrible with drops. It's the only way I can get drops in my eyes. I hold my lower lid down, I go up to the mirror, I put the thing in, and then I let my lid go up. And it's the easiest way in the world to put drops in. Ben, can blepharospasm cause headaches?
Boy, that's
For the patient, not for you.
Yeah. That's an interesting question. I don't think that I've seen that. As a neurologist, I'm actually also a headache specialist, and so I deal with a lot of unusual headache issues. Headache in of itself is a pretty common condition, and theoretically I could see if you're having a lot of muscle spasm around the eyes where that could contribute, but I have to say I've not really seen that as a problem. I've had patients with blepharospasm who have chronic migraine. I mean, I've seen that, but I'm not sure there's an increased incidence of headache or that blepharospasm specifically causes headache. I've seen other eye issues cause headache.
That's interesting, isn't it? Because as a headache specialist, don't you make the diagnosis of muscle contraction headache frequently?
So muscle contraction headache is an old term. We now call it tension-type headache.
Oh, well.
And it has nothing to do with contraction of muscles. In the same way that Botox doesn't, for those kinds of headaches, Botox doesn't do anything. It works in migraine. It doesn't work in tension-type headache where you assume that the muscles are tense. And by relaxing the muscles, it helps headache. It's not, Botox doesn't work for that kind of headache.
Okay. There was a question here about someone who, every time they get Botox injection in the lower lids, they get this unsightly puffiness in their lower lids to the point where they stopped getting the injections. Is there anything you can recommend altering the technique to, do you all see puffiness in the lower lids with injections? I don't see it.
Not that lasts longer than the time for the medicine to do.
Exactly. So I don't see it. So I don't know why the person said that. However, I mean, I don't understand, even if you have baggy lids or excess skin, it shouldn't happen because you put in so little fluid that it shouldn't cause any problem.
It could be that if the orbicularis is weakened enough that it's not squeezing the extracellular tissue fluid away, and if they are prone to accumulating some, just like people get swollen feet, if they sit for a long time, it may be that they're just not pumping the normal fluid away.
But you don't inject enough fluid in there to cause...
No, I mean long-term. If they
Oh.
if they have muscle weakness, then they may not be using the normal pump, muscular contraction to squeeze the tissue to get fluid to mobilize, and it may accumulate.
Are there any exercises that can be done to influence the blepharospasm, maybe some to improve muscle nerve coordination, sort of biofeedback and stuff like that, Dr. Wu?
Yeah, we have thought about that quite a bit, and we've tried to put together some neurologically trained physical therapists to address cervical dystonia, hand dystonia, arm dystonia. We've even addressed runner's dystonia. And I posed this question to them at one of our meetings. I said, we have some basic menu of things that we do for exercise, but we don't for blepharospasm. And they sat there and said, we can think of some things. And we haven't gotten into it as much. Now, you do have these late-night TV anti-wrinkle electrical stimulators that you see being marketed, where you can wave a wand over your facial nerve and it'll twitch your face once every 8 to 10 seconds. I have no idea what that actually does. It works just fine for twitching your face, but I don't know if it's actually training you. What we do in the hand and the neck dystonia is we actually do things like we put mirrors in front of them. We'll use TENS units. I'm going to talk about one novel use of a TENS unit in blepharospasm a little later today. But we don't have the menu of options because we can think of a lot of things to train hands to do. We don't have as much to do with eyes, though I think if we're creative, we can work together. And so I again, take a lesson out of your book. Who has devised a training plan that seems to work? Does anyone train their eyelids in certain ways in front of a mirror or anything?
Sit. Stay.
Yes.
Stay open.
Yeah.
Got to give them the
Dr. Wu,
commands.
can whiplash or any other neck or shoulder injuries cause blepharospasm because of neurologic damage?
No, it's one of those things like the headache question, where whiplash neck injuries are pretty common. Blepharospasm is not very common, but we see it. I can't think of a clear link between whiplash and blepharospasm. You can kind of imagine one with cervical dystonia, but it's not the thing I would think about for blepharospasm. But again, every case is individualized.
So plaintiff's attorneys should not call Dr. Wu to testify for the patient.
Can't prove it.
Natalie, is there any reason why a patient with blepharospasm can't have LASIK surgery?
Yes. So we don't recommend LASIK surgery because dry eye is so common, and post-LASIK, one of the possibilities after LASIK is dry eye syndrome. So we don't want to start off, have a reason to actually exacerbate that or to have that more commonly. So we don't recommend LASIK unless everything else is quite perfect and really we have a long discussion, but typically not.
Okay. Does Botox migrate when you inject it?
Yes.
All right.
Yes.
Next part of the question, can it migrate into the optic nerve and cause blurred vision or affect your eyesight?
No.
No.
Well, yes and no.
It can get into the muscle and
It
affect
can't migrate into the optic nerve and cause optic nerve damage. It can cause blurred vision. It can cause blurred vision if the eye doesn't close well, the blink is decreased, and the eye dries out. We already learned about how important the cornea is in focusing. And so if you have a tear film abnormality, you're going to have blurred vision. It's a common reason to have blurred vision. Another thing is if you do have, if you develop ptosis and the lid is drooping enough that it's covering half of your pupil, you can develop some monocular double vision. You can develop binocular double vision from having the medication diffuse to one of the muscles that moves your eye so that you have an eye muscle imbalance.
How often do you really see that?
I think I've seen it twice in 25 years.
Yeah, I mean, I always tell people you can get some double vision and the like. The people I've seen it in are the people who have had blepharoplasties, where the orbital septum has been violated on purpose surgically, and there may be some diffusion. The Botox, the botulinum toxin does diffuse, and that's why you can get ptosis droopy lid. If you inject it too much in the upper lid, you can get a droopy lid. But if you stay away from the muscle that keeps your lid up, you shouldn't have ptosis I very rarely get ptosis. My biggest complication is sort of hematomas, because you don't know where you're injecting until you see and I tell my patient, the worst hematoma I ever caused a patient was in my wife. I sort of injected her for the wrinkles, and she came in and she had this hematoma down her face, and man, did I live in agony for 3 weeks until, can't you have your partner who's a plastic surgeon take care of this for me? No.
If I could add one thing on the spread of toxin, this is from the research side. It's very clear that botulinum toxin injections, as we're doing them, are safe. But there are really, really well done, well-controlled studies that now show that when you inject toxin into peripheral muscles, it does track backward along the nerve, innervating that muscle back to the central nervous system. The clinical significance of this is not clear, but it underscores the idea that regardless of what we talk about with our patients, this is a very potent neurotoxin. And I teach that we have to respect that, regardless of what we do.
And that's true. There are those articles that show very nicely that it tracks back, but there does not seem to be, as of yet, any clinical significance. I have a question here that sort of goes to the issue of people sort of going from doctor to doctor to doctor before the diagnosis is made. Mary Lou, this is for you. It says, what is the foundation doing to educate neurologists and optometrists about blepharospasm? You notice the questioner didn't put ophthalmologists, but I would add ophthalmologists. I will tell you that ophthalmologists always call it dry eye. Neurologists, I can't tell you how many people I've seen with blepharospasm who have been worked up and treated for myasthenia because their eyes are closed. What is the foundation doing for educationally to target neurologists and optometrists?
Well, Barbara, would you stand up, please? Barbara and her husband, Charles, just attended the Neurology Academy meeting here in San Diego for 6 days, constantly, all day, handing out more literature than you've seen out here. And we see all the neurologists that come to a Neurologist Academy from around the world. In November, I will be going to the Ophthalmology Academy. As I told someone, somebody has to do it, going to New Orleans. So we will be showing videos. We will be talking to ophthalmologists around the world. And we also have several doctors that will be conducting sessions, especially on blepharospasm and MAGE, not hemifacial. But we are in that area. We constantly have doctors on our mailing list that they receive all the information you receive. And the number one thing we are proud of that they receive, or would be, our newsletter. Because I want to tell you, when you send in questions, and like today, the questions that you have submitted, we will be putting those in the newsletter. I cannot tell you how many times a doctor will come up with another doctor and say, I want to show you what this group does. They'll turn to the back, that's where we always have it, ask the doctor. And who answers those questions? Dr. Savino, and whomever I can get or we can get, mainly our medical advisory board. So doctors look at that You send in the questions, and Dr. Edwards, was it you? No, I think it was Dr. Korn that said the patients are the teachers. I want you to know you really are, because you send the questions, the doctors answer, but you are the teachers. And Dr. Savino, would you not agree?
Absolutely. I learned more from running my group in Philadelphia than I ever taught to people there. So that the foundation is in fact doing a lot to educate. And I will also add that they're doing more than that. They are now funding research. Dr. Wu stated that he was a recipient of one of our grants. So the foundation is very, very important, not only educationally, but to spur and to support research that hopefully at some point will give us more and more of the answers that we need for this disorder. I did not call it a disease because someone objected on a question to it being called a disease, and I don't know that anybody calls it a disease. I've never heard that. Panel, yes?
I do have a comment about the delay in diagnosis, and dry eye is highly prevalent. Maybe 25% of the population has dry eye. Blepharospasm is not highly prevalent. 1 person in 10,000 has blepharospasm. So when you go to an ophthalmologist or an optometrist or your primary care physician and you've got a complaint that you're blinking, there are so many other things that are more common that can cause blinking. And when you first start with your symptoms of blepharitis, it is not as obvious as it is 2 or 3 years after you've been into the disease. So it's not unusual or unexpected that the diagnosis might not be picked up right away. And I don't say this to say, well, you should just allow people to misdiagnose you, but I think you shouldn't think that the first eye care provider that you see who didn't get the diagnosis right didn't know what he was doing. You should rather be aware that it's quite likely that he was working you up in the appropriate manner and your disorder wasn't apparent enough. We see that in other diseases as well, where somebody presents to somebody and it's not clear what they've got, and then sooner, not 4 years later, but weeks later or a few months later, the disease is apparent, but they're seeing another doctor, and so they think the first guy was totally wrong.